Hello, guys. Good evening. As you could see, we are back on another live, and at this time, we will be presenting the endocrine diseases, disorders. Okay, or disorders. So endocrine disorders. So let me share my screen with you. But before we would begin, let's have a quick word of prayer. Father God, thank you for allowing us to be on this platform as we're going to discuss endocrine disorders. May this learning be effective and bless someone. In Jesus' name we pray. Amen. Okay, guys, let's share our screen here, and we will be going over endocrine disorders. Okay, hopefully everybody can see my screen. So what is the goal of endocrine disorders? So we're going to focus on the pathophysiology of some endocrine disorders, not all of them, but most of them, risk factors, the causes, signs, symptoms, complications, risks and complications, and also untreated outcomes, the goals. If they're not untreated, what will happen to those type of disease disorders, or medical treatments, and as well nursing interventions. Okay, and at the end, as you all know, we always have some treats for you and clicks just to test your knowledge. All right, guys, hopefully this presentation will help you to close your knowledge gaps on endocrine disorders. So the first one we want to talk about is thyroid disorders, hypothyroidism versus hyperthyroidism. Just so you know, I suffer this thyroid problem for years. Okay, just so you know, I suffer with this thyroid problem disease for years. Usually, they said it's after the your first male child, um, or it, it's an autoimmune. Some people say, okay, and another name for it is Hashimoto's thyroiditis, which is the most common cause of hypothyroidism. And as we said, the immune system can be mistakenly produce antibodies that attack and destroy the thyroid gland. So that reduces its ability to produce enough hormones. So while other causes can be existing, so Hashimoto's is the primary cause in developed uh, nation. So that's just so you know. And it is a chronic problem. Immune cells infiltrate the thyroid that can cause chronic inflammation and destruction of thyroid tissue. So just so you know. So leading cause where you have the patient would have an underactive thyroid problem. So just so you know. Now, pathophysiology, you have a decrease of T3, T4. Okay, you have T3, T4, decrease of that, and also decreased metabolism. And that's really your energy gland. That's what I usually call it. Your thyroid is your energy gland. Okay, um, it's your energy gland. So when you have hypothyroid, so basically your um, your energy, it can be very low. Hypothyroidism. Okay, so just so you know, energy gland. So just so you know, hypothyroidism occurs if the pituitary gland fails to signal the thyroid. So just so you know. Um, so what happened is the causes we said Hashimoto's. So sometimes people with thyroidectomy, if say their thyroid is removed, or they have deficiency of iodine or lithium, that they can develop hypothyroidism. And we said female, that's usually most common with hypothyroidism. autoimmune disorders like elderly patients. It's not just younger patients, but also elderly and postpartum patients. So we said it's your energy gland, it's down. So I've had this problem after I had my first male child, and I've had it for years. My doctors didn't know what was happening. I was weak. I had all the symptoms that you guys gonna see we mentioned here. My metabolism was slow. My TSH was very high, and you all know TSH could be from what is it? The normal TSH. Um, could let me see, level normal range. So you have zero point 0.5, some textbook says zero point 0.5 to 5 uh, MIUs per liters. So mine was actually very high, close to 200 was very high. And my total cholesterol was also elevated. So my metabolism, and I was weak. So metabolism is really slow. So now, fatigue, weight gain, because you're not moving your metabolism, you're not burning the calories of fat. So of course you're prone to have weight gain, and very sensitive to cold. The hair, dry, straw, brittle, prone to break. You also have dry skin, bradycardia. That's very important. Usually it's an NCLEX question. The heart is not pumping effectively, so you don't have normal, or if, unless if it's very bad, your heart rate can be below 60. That's why when you take that Synthroid, one of the goals is to make sure your heart rate is 60 above. So you tend to have bradycardia, constipation, dry skin, like I said, even depression, and your libido is also low. Now, what would be some complications of hypothyroidism? If it's not treated, it can be problematic. So, complication of hypothyroidism is myxedema coma. It's different than hyperthyroidism. Myxedema coma would be the complications of hypothyroidism. Heart failure, infertility. Thank God I was able to still produce. I had two other children after that, but some people don't even have children, infertility, due to really severe case of hypothyroidism. So if untreated, the patient can develop hypoventilation, coma, even death. So that's why it's important. You got to stay on your lab, your blood work, and make sure you take your TSH, your T3, 4, T4, T3, your lipids panel, your triglycerides. I'm talking about what else? Your total cholesterol, um, your HDL, your LDL. You want to make sure the lipids panel, the labs are correct, and make sure you check your doctor. So medical treatment, sometimes they would place you, and that can be lifelong, on levothyroxine, which is a generic name for what is it? That's for the drug, levothyroxine. So now, just so you know, insurance, it's very cheap. A bottle can cost $4, but it can cause bone pain. Just so you know, not everybody can tolerate that. I was not able to tolerate a levothyroxine. However, I can tolerate Synthroid, which is the brand. But if Synthroid is more expensive. Usually one bottle for 30 days is $40, right? Close. And some insurance, they don't want to pay that much. Okay. All right. That's out of pocket. Okay. 30, $40. But it could be more if you don't have insurance. It could be $100 over. So severe IV thyroid hormone. Okay, that could be other treatments. So nursing priorities is to maintain airway and monitor respiratory status, and especially if they had surgery. After surgery, monitor heart rate, because remember we said they have bradycardia. Prevent hypothermia because they're sensitive to cold, warm environments. Avoid sedatives and opioids because that can trigger the disease. So NCLEX tips, we want you to remember the hypo, it's low and slow. Everything is slow and low. Energy low, even the heart rate drops. That's what you need to remember. That's your energy gland. Everything slows down. Now, hyperthyroidism is the opposite of hypo. Hyperthyroidism, guys, the pathophysiology is, remember, your T3 and T4 was low in hypothyroidism or Hashimoto's, and now here it's high, it's elevated. Your T3 or T4 is elevated. So that's your hypermetabolic state. So your patient is able to burn a lot of calories because their metabolism is super high. So that means they're at risk for what? To be skinny. They lose more weight. Whereas in hypo, they tend to gain weight. So causes of your hyperthyroidism is grave disease, thyroid nodules. Okay, sometimes I used to have the nodules. Okay, no more. So just so you know, for hyperthyroidism is grave disease, thyroid nodules. Risk factors, we said female again. Stress can also cause that because remember, they also said it's autoimmune. That could cause that. The cells are attacking each other, and that could lead to infection. Signs symptoms of hyperthyroidism is opposite from hypo. We have weight loss, heat intolerance comparing to cold, tachycardia comparing to bradycardia, tremors, anxiety, diarrhea, right? Exophthalmos, where the eyes are bulging, right? So that's our signs of your hyperthyroidism. Complications, if not treated, the patient will have something called thyroid storm, and this is an emergency. Okay, they can die from it. So atrial fibrillation, where the heart is beating super fast, could go up to 300 beats per minute. We don't want that because that means if you have AFib, what do you think you're at risk of? Clots. And complication of atrial fibrillation is stroke. So they could die from that. Heart failure is also a complication of hyperthyroidism. If untreated, we said patient may have severe tachycardia, shock, even death. And medical treatment would be what? Medication, the PTU, which is methylmazole. PTU is parathyroxine. It's a pill. And just so you know, the beta blockers, that could be just to help with the rate of the to lower the heart rate and all that. And sometimes they place the patient on a radioactive iodine surgery. Okay, so best way to learn those diseases is compare and contrast and have index cards or concept map. That will help you a lot. So nursing interventions for hyperthyroidism is monitor cardiac rhythm, vital signs, reduce stimuli, calm environment, provide high caloric diet, watch for thyroid storm, fever, tachycardia. Okay, so remember NCLEX tips, things of hyper, fast, and hot. Okay, now remember medical intervention, nursing intervention, signs, symptoms. And as nursing, what is your priority? Now, remember also for hypothyroidism, when they're taking their Synthroid, the best time to take it is early in the morning, and it must be given before breakfast because it needs to be absorbed in the stomach. That's the best way they absorb the medication. So, just so you know, for thyroid medications. What about the next problem is ADH disorders. That's antidiuretic hormone. The antidiuretic hormone, which is SIADH. SIADH. Okay. Okay. Do you guys see my screen? Okay. All right. So SIADH. So is it from the pituitary problem? Right? Yes, it is. A syndrome, SIADH, a syndrome means syndrome S. I for inappropriate, A antidiuretic, H for hormone secretions. It is from the pituitary gland, right? It's a pituitary problem. It's often caused by a malfunctioning of the pituitary gland or hypothalamus, right? your thermostat center, which result in the excessive release of ADH, leading to water retention and low sodium, which is hyponatremia, and can stem from CNS disorders and lung disease, medications, and pituitary surgery. So you all understand, when you have too much of ADH, that means you're not releasing the water, you're retaining it. And that's what it is, anti-diurese. So you're not diuresing, so you're retaining. So you basically have retained fluids, right? And sodium, you would understand, wherever you have sodium, you should have a lot of water. That's why you have a lot of water. Wrong. In this case, it's not. The problem is the sodium is not being diluted here, okay? Actually, it's diluted. Comparing, it's been diluted, and that creates confusion, because when you have low sodium, what do you think? Patients are at risk for confusion, even hernia in the brain, essentially seizure. So the sodium has been diluted in all the excess of water, so the sodium becomes low. So they're at risk of seizure, decreased LOC, confusion, concentrated urine because of all this urinary retention. So complication, we said cerebral edema, that makes sense, seizure, even coma. So that is not good with your SIADH hormone, okay? SIADH hormone. So while ADH is produced in the hypothalamus, it is stored and released by the pituitary gland. So just so you know, and that area can trigger the SIADH. So now brain injuries, head trauma, stroke, infections can also cause the pituitary to release too much ADH. So surgery, procedures affecting the pituitary gland or hypothalamus can also cause SIADH. We're talking about causes of SIADH. So just so you know. Now, other causes could be SIADH is frequently caused by small cell lungs cancers, which produce its own ADH. Medication like antidepressants, according to research, can also cause that, or certain lungs infections. So common signs, symptoms of your SIADH, we said headache because of all these fluid retention. Think of fluid overload. You have headache, you have nausea, you have vomiting, severe cases, confusion, coma. So definitely they would do testing for blood, urine, and treatment focuses on restricting fluid intake. So these people, even though their sodium is low, but they're on fluid restrictions, ionos, and sodium, they would need to replace that because their sodium is low. So medical treatment would be what? Fluid restriction, like we said, hypertonic solution, like the 3% sodium. Even if they can take it by mouth, they would give them sodium chloride and 18% your hypertonic solution to increase the sodium level, and vasopressin antagonist. So that's what they would need. So now your nursing interventions is, you hear seizure precautions. So pat the side well, strict INOs, make sure you weigh your patient daily and monitor the sodium, their labs. That would be the BMP or the CMP, and neuro status, very important. So soak, what you need to remember, SIADH, you are soak inside, fluid overload. So that's your nursing intervention, and that's your nursing diagnosis, I mean. So what about DI? DI is the opposite of SIADH, which is your diabetes insipidus. It is not it's not related to the diabetes. Okay? Well, what is it related to? What is it related to? Okay? So it says diabetes insipidus is not related to common blood sugar diabetes. It does not involve insulin. So that's why it's not, because remember, it's a pituitary problem, part of the brain. It's rare condition involving water imbalance caused by a deficiency in resistance to vasopressins, antidiuretic hormone. It leads to extreme thirst and excessive urination. The two conditions share similar names and symptoms, such as excessive thirst, but have completely different causes and treatments. So that's your DI, which is um, diabetes insipidus, but it said it's not related to the blood sugar. Okay. Now, causes of your diabetes insipidus, we said it's caused by a problem with the kidneys or pituitary gland, specifically insufficient vasopressin, okay, production or poor kidney response to it. Okay. So signs, symptoms, what would be some signs, symptoms? So we said pathophysiology is decreased ADH, massive water loss, dehydration, because they pee a lot. So these people, if you were to check their urinary specific gravity, there we have a high urine specific gravity because it's what? Actually, it's gonna be low, guys. Remember, when patient is dehydrated, the urine specific gravity is high, is elevated. But in this case, they diuresing so much, the urine specific gravity would be low. Okay, just so you know. Causes of pituitary surgery, head trauma, and lithium. That would be the causes of diabetes insipidus. So now you have polyuria, polydipsia, just like they have diabetes, but they're not. Okay, it's not related to blood sugar, diabetes. Hypernatremia. So instead of having low sodium, like in SIADH, here they have high sodium because the sodium is not being diluted here. So dehydration, hypotension, dilute urine. Okay. Complications of DI is severe dehydration, hypovolemic shock, electrolyte imbalance. Okay. If untreated, what do? Circulatory collapse, shock, death. Medical treatment, you have to remember DDAVP, which is hormone, desmopressin. And also, instead of giving the patient hypertonic solution, you want to give patient hypotonic solution, like your 0.45%. Okay, not isotonic, not 0.9, but you're gonna give them what? 0.45, half of the normal saline or isotonic solution. Nursing priority is to monitor urine output hourly, replace fluid promptly, monitor sodium level because remember that sodium is super elevated, assess for dehydration and hypotension. So remember, DI is dry. They're dry, they need fluid replacement, okay? Because they're losing a lot of fluid. So now let's go into adrenal disorders. Adrenal disorders, as you could see, we've gone over the your thyroid problem, which is thyroid problem, right? Then you have pituitary problem, which is your SIDH and DI, and now we go into the adrenal disorder, which is on top of the kidneys, your adrenal glands are. So Addison disease, and we're going to see Cushing disease. Cushing disease. So Addison disease. The pathophysiology of that is what? You have a decrease of what? Cortisol. Remember, cortisol, it's a hormone. During stress, it's elevated, and under stress, it decreases. So under Addison's, just think everything is slows down. So then you have decreased cortisol and aldosterone. And you think of aldosterone, you think salt, the hormone that balances your blood pressure in the body, and salt. So inability to respond to stress. They're not able to respond to stress because their cortisol is low. So that causes is what? The causes of Addison disease could be autoimmune destruction, right? TB or steroid withdrawal. So people who withdraw from steroids, sometimes they are at risk for Addison disease. If they have TB, they're at risk for Addison disease or autoimmune destruction. What would be some signs, symptoms? Signs, symptoms would be what? They have low blood pressure, fatigue, weight loss, hyperpigmentation, hyponatremia, they got low sodium, they got hyperkalemia, okay? So just think of everything is low. Hypotension, low blood sugar, low blood pressure, okay? However, their potassium is high, okay? So hypotension, fatigue, weight loss, hyperpigmentation, hyponatremia, but hyperkalemia. The only thing is high is the potassium. Now, complications, Addison disease is Addisonian crisis, okay, where they have severe hypertension and shock and low blood glucose, right? If untreated, the patient could have cardiovascular collapse, even death. So medical interventions for your Addison, remember they need to add what? They need to add water. So they're weak, so they need hydrocortisone. They need the hormone to replace that, as well as fludrocortisone. So steroids, they need that to balance that hormone. IV fluids because they're dehydrated, and glucose during crisis. Okay. Nursing priority, we said monitor BP, signs of shock, monitor electrolyte imbalance, their BMP, CMP, that's your sodium, and remember the potassium we said is elevated, the sodium is low. Administer corticosteroids as scheduled, prepare for stress, dose steroids during illness. And remember cortisol, an NCLEX step, think of low cortisol, and patient is at risk for shock because of the dehydration. Now, what about shock? Cushing syndrome, I'm sorry. Cushing syndrome is the opposite of Addison disease. And remember, we said that's adrenal problem. And now, pathophysiology of Cushing's, we said that's excess cortisol. Cortisol, again, that's the hormone that releases during stress, and it's elevated, right? And now, remember, it was low in Addison, but in Cushing's, it's elevated, okay? It's elevated, and that's what's caused what? Glucocorticoids hormone, which is cause hyperglycemia, immune suppression. And the causes of Cushing's, that's long-term steroids therapy. So too much steroids, of course, you already know that puts you at risk for infection, immune problem, pituitary tumor even. So signs, symptoms of Cushing's, we have moon face, buffalo hump, hypertension, hyperglycemia. So everything is elevated with this patient. They even have petechiae. They have even risk for fractures, weak bone, right? They have this moon hump back, okay? And they have moon face. They are basically swelling up. And thin skin, that's what they are risk for, bruising and petechiae and muscle weakness, and even risk for fractures. Complications, severe infections, diabetes mellitus because of the glucocorticoids. You got to check the blood sugar. And osteoporosis because of the fractures, the weak leg, and thromboembolism. They are at risk for clots, guys. If untreated, Cushing's can lead to sepsis, cardiovascular disease, and death. So how do we treat Cushing's medically? Gradual steroids, taper it down. Remember, never encourage, or when you teach patients when they're going home, if they want to wean from their thyroid, their steroids, they got to do it gradually. Usually they have to follow the doctor's order. The doctor's order is very explicit, detailed, and tell them how they take it. So gradual steroids, taper it down. Tumor removal, that could be a tumor related, so they would have to remove the tumor. Nursing priorities to monitor glucose because that's elevated, the blood pressure, prevent infection because of the steroids, protect fragile skin and petechiae, assess the skin daily, encourage high protein because remember it got weak bones, low sodium diet because their sodium is elevated. So NCLEX, remember high cortisol, infection, and hyperglycemia. Now, what about parathyroid disorders, hypo versus hyper? Whenever you think of parathyroid, that's the gland that's located behind your thyroid gland, and that's really the electrolyte that is what? Calcium. When you have a low calcium, that's hypoparathyroid. So usually too much low potassium can lead to what? Tetany, laryngospasms, and seizures. So they would have to test BMP, check the level of calcium, and they also do what else? Remember the Chomsky signs, and then the Trousseau sign. Untreated, Airway obstruction can happen if left untreated, and respiratory distress. The nursing priorities after surgery: maintain the airway. That's very, because remember, it's located right on the trachea behind the thyroid gland. So monitor calcium levels, monitor seizure precautions, administer IV calcium gluconate. That is the treatment for hypoparathyroidism and hyperthyroidism, and when you have too much calcium. Also remember, they would, for hypoparathyroidism, they got to then one of the hormones they can do is calcitonin, right? That's for low calcium. So parathyroidism, now it's high, that's due to too much calcium. And complications could be kidney stones, bone fractures, cardiac dysrhythmias. If untreated, the patient can have renal failure and lethal arrhythmias very badly. So nursing priorities for hyperparathyroidism is what? Promote hydration, prevent stones, monitor ECG for dysrhythmias, encourage mobility, reduce bone loss, monitor calcium levels. Also, for they do ultra high yield, what is it? They could do surgery. So now remember, nursing priority for each of those diseases. Hypothyroidism, we said airway and respiratory status. And also a Synthroid that needs to be given before breakfast early in the morning. Hyperthyroid thinks of cardiac monitoring, right? Because of the tachycardia and AFib. What about SIADH? Seizure precautions, DI, fluid replacement. What else? Addison, think of dehydration and the potassium. Monitor BP Cushing's. Everything is elevated. The glucose, and patients at risk for seizure, not seizure, but the blood sugar, right? And also immune problem because of the steroids infection. And for hypoparathyroid is the tetany, airway protection, very important. And for hyperthyroidism, think of hydration and ECG monitoring. All right, guys. So some golden critical thinking rules you need to remember: for cortisol that is low, patients at risk for shock. Cortisol that is high, patients at risk for infection. Steroids, you never stop them abruptly. Sodium, we need to check for neurostatus, seizure precautions, and all that. Okay. Now let's go with our questions and clicks questions, and we'll be done for the night. Okay. A patient with SIADH has sodium 118 milligram per deciliter. Priority nursing action would be what? A, encourage oral fluids. B, encourage seizure precautions. C, give hypotonic solution. And D, administer desmopressin. What do we do if somebody has SIADH? Remember, SIADH has fluid volume overload. And what problem is that? That's pituitary. So what do we do? Your priority nursing action. The sodium is low. So what do you think? Patient is at risk for a seizure, right? Brain herniation. So the answer is B, initiate seizure precautions. Severe hyponatremia can lead to seizure. That's the problem with your low sodium. Next one. Let's see. Which finding indicates effective treatment of diabetes insipidus? Remember, we said diabetes insipidus versus SIADH, a pituitary problem. So what is it? Do you use specific urine gravity increases? Does urine output increase? Does sodium increases? Does your weight loss occurs? Or DI, overly hydration? Yes, the answer is A, urine specific gravity increases. What finding indicates effectiveness of the treatment? Remember, I told you, if somebody has overly diuresing, they're pouring, they have polyuria. So their urine specific gravity will be low. So the goal is to increase their urine specific gravity. So that's why it says which finding indicates effectiveness of DI. So it's increase of the urine specific gravity. And that's the answer. And that makes sense. Okay, next one. Post-thyroidectomy patient develops stridor priority. Okay. After thyroidectomy, the patient develops stridor. What is your priority? Do you check calcium level? Do you prepare for re-intubation? Do you give levothyroxine or do you apply ice? Post-thyroidectomy, remember, always have your suction kit at the bedside. Airway should be your priority, right? Always. So what do? You don't have those options here. It says check level calcium, prepare re-intubation. For re-intubation, give thyroid pyroxene, or prepare, apply ice pack. The answer is B, prepare for re-intubation. So in case, remember, airway, stridor. Airway, it's an obstruction in the airway. So that's an emergency, so they have to intubate patient. Number 4, Addison crisis, expected labs. Remember, we said their sodium is low, blood pressure is low, everything is low, but their potassium. So Addison crisis, expected labs, what would it be? Would it be hypernatremia and hypokalemia, or hyponatremia and hyperkalemia? Or would it be hyperglycemia or low BUN? These are very interesting questions. I'm loving them. Addison crisis. What do you expect the patients to have? What's the answer, guys? The answer is B. Remember, the potassium is elevated and they have low sodium. So B is the answer. Aldosterone deficiency, that's what they have. Number 5, Cushing syndrome, client priority complication. Cushing syndrome. Would it be infection? B, hypoglycemia. C, bradycardia. And D, weight loss. With your patient who has Cushing syndrome, what is their priority as a nurse? What is it? What is it, guys? The answer? What is the answer? The answer is, you guys got it? A, infection. Remember, that's the glucocorticoid hormone, increased cortisol. So you know they are at risk for infection. Gotta monitor their blood glucose, very important. What about the next question? Which meals is best for hyperthyroidism? Remember, they need to be on a what? High caloric diet, guys. Would it be low caloric, low protein, high caloric, high protein, or low carbs only, or fluid restriction? I already gave you guys the answer. The answer is B. Yes, high caloric, high protein. Next one, which assessment confirms hypocalcemia after thyroid surgery? You have a lot of signs you have to do. Do the Trusa sign, do the Chovic sign, right? Is it the exophthalmos? Is it the Trusa sign? Is it bradycardia or the moon phase? You already know it's the Trusa sign. Next one, number 8, we're almost done. Priority assessment in myxedema coma. Myxedema coma, remember that's a complication of what? Hypothyroidism or hyperthyroidism? Hypo, good job. If you say hypothyroidism, you are right. That is a complication for hypothyroidism. And for hyperthyroidism, the complication is thyroid storm, right? The grave disease, right? So the question is priority assessment in myxedema coma. Is it respiratory status? Is it skin turgor? Is it pain level? Or is it urinary output? The answer is hypoventilation. Because remember, patient has what? Hypothyroidism. That's the main cause of death, respiratory status. Okay, very important. Remember, they also have bradycardia as well. Number 9, patient on long-term steroids should report what? Long-term, would it be mild? They need to report mild fatigue. B, fever and sore throat. C, increased appetite and insomnia. This is another easy question. We know with steroids, they're at risk for what? Infection. So report what? Sore throat, guys. B is the answer. Last and not least, which findings suggest thyroid storm? A, bradycardia, hypothermia. T, tachycardia, high fever. C, constipation. And D, lethargy. Which findings suggest thyroid storm? Where do you find thyroid storm? This is a complication again of hyperthyroidism. Would it be bradycardia, hyperthermia? Or would it be tachycardia, high fever? Or C, constipation? Or D, lethargy, guys? The answer is thyroid storm, extreme hypermetabolism, and the answer is B, tachycardia, high fever. All right, that is the end of our endocrine disorders, guys. Thank you. Oh, I had a lot of people here. Thank you for joining us. And hopefully, guys, you'll be able to master your skill on endocrine disease. I have another video on diabetes, which is also part of your endocrine. So that is a separate video that I did last month. So you guys can also watch that. I talk about all the types of insulins, complications of diabetes, and what do you do? When do you expect that patient to go exercise? When you expect that patient to to take their insulin? Depends on the insulin they're taking, whether it's high what is it, fast acting. No, the first one is what? Rapid acting. And then you have short acting. Then you have NPH. Then you have long term. And also the type of coverages we have: basal coverage, sliding scale coverage, nutritional coverage, all of that. So very interesting. So this is the end of our endocrine disorders, and thank you very much. I don't know if you guys have any questions. You can watch this video over and over and share it with a friend. I know some of you do have exam coming up. So this was a request from my students to do a review, and it was my pleasure. Hopefully I make it plain and simple. That's always my goal. And enjoy the video. All right. Have a good night. God bless. Thank you. Bye.